Welcome, friends. This is Dr. Jaitly, your cardiologist from New York. Welcome to MuniMeterHealth. So that's your favorite video site for learning medical education as well as patient health education, as we are promoting both in order to improve the clinical outcomes, and nothing like the combination of the medical fraternity educating themselves and the patients educating themselves in order to improve the clinical results. And that's been proven beyond doubt now. Now, obviously, if it's an emergency, you are better off calling 911 and straight going to the hospital, consulting your doctor, or else get to the nearest hospital or doctor's clinic. And for medical students, I always advise this is not a substitute to your syllabus. It's a supplement, and you can stick to your syllabi from your universities and your societies as prescribed, but to use this as a second backup or a quick brush up, if you like. And thirdly, I would like to say that it's not a medical advice site either. It's totally an educational site, as I clearly pointed out. It's medical education, patient education. So without any further ado, welcome again to MuniMeterHealth, and let's discuss in this short video what are the clues for secondary hypertension, if you will. Interestingly enough, we know that most of the times it's an essential hypertension. We know that. Now, that's the garden variety of hypertension that you'll see classically in a setting where in men normally past the age of, say, 50, and women past the age of, say, 55. This essential hypertension sets in because of the hardening of the arteries and, atherosclerotic mechanisms where the plaques will start to form. And here's an artery that I'm drawing, and of course I can show some plaques from a different color here. And as you see, these plaques are primarily occurring. They start at the age of, by the way, at the earliest at the second decade. You'll be surprised to hear that. However, the hypertension really creeps in at around this age, and that's the essential hypertension. So the arteries are non-elastic now. They become a little more stiffer, and the moment they become more stiffer, so the heart has to pump with greater force to push it through. And remember, if it's like I'll constantly give you an example where if you have an artery which is pulsatile and more elastic, then the heart can actually pump it better, obviously, because it's like more of a tube, if you will, if you wanted to inflate it through a tube. But if you have a hard, say, a lead pipe, for instance, or a very, very stiff pipe, then obviously it takes a little longer takes a bigger force to pump it through. So having said that, now elasticity is lost in the essential hypertension. But here we are discussing secondary hypertension. What do we understand with that? That means the causes could be numerous. You could start, say, from let's draw the kidneys here, for instance. It could be renovascular hypertension, and the right kidney we know is slightly lower than the left one because the liver just belongs here, if you know. And so renovascular hypertension will actually be somewhere like this, where the arteries could be narrowed, and again, it's an atherosclerotic process. It starts the age of 45, 50 more or less. So renovascular hypertension, sometimes you may hear the bruits. So that's maybe a clue that the bruits may be present in the flanks. Now, there might be a bruit that you could hear in the back, and that's related to, here I'm drawing something that gives you a clue. That's the coarctation of the aorta, guys. Okay, so this is the great vessels that are rising from the arch of the aorta, and of course the heart belongs here somewhere. And as a result, now you have coarctation. So the coarctation normally occurs distal to more or less the great vessels, and so this coarctation could be heard as a bruit. So sometimes you can hear a bruit in the back. This is in the flanks. You may hear the bruit. Serum potassium will give you some clues that if the persistent potassium is low, like specifically it should be markedly low, like 2.0, 2.5, 2.3, etc. Again, in the absence of any diuretics and any other medicine, just to make sure that the patient is not on any, and if it persists and the patient is markedly hypertensive, then you could draw the conclusion that this is primary aldosteronism unless proven otherwise, and start to work on that patient up like that by getting maybe a sonogram, or even a CAT scan will show the adenoma sitting right on top of the kidneys, and you know where the adrenals are. Adrenals are right on the top here. So this is where the adenomas will be, and that's your Conn syndrome, if you will, or primary aldosteronism. Okay, so potassium will give you a clue. Creatinine will give you a clue, obviously, because of the kidneys' functions are deteriorating. If the kidney functions are deteriorating, then you know that's CKD is starting to set in. So CKD could be a cause for, and the creatinine values will start elevating like 2.5, specifically so if ACE or OBS are being added, those groups of drugs are being added. So that'll give you another clue. Thyroid functions could be tested. That's normally done on a panel now these days. It's very routine. TSH and T4 will give you an idea whether this patient is developing hyperthyroid, is already having hyperthyroid. And these patients are very, very shaky, tachycardic, very anxious. They have warm, sweaty handshakes. This is classically described in the textbooks, and of course, even in the clinics, they're constantly having the wet hands. You can like they just wash their hands. Looks like, you know, they're so sweaty all the time. They're very warm. So that's the hyperthyroid handshake, we call it. Cushingoid facies, of course, that'll define whether glucocorticoids excess will lead to Cushingoid facies, where they're more mooning of the face, if you will. Acromegaly, of course, they are very, very tall personalities. They're almost 6'8", 6'9", 7 feet sometimes, and they have the prognathism of the jaw, the lower jaw, the mandible, and so acromegaly facies. And the myxedema, where there is huge swelling in the throughout the skin, especially under the tissues or the subcutaneous tissues, but it's non-pitting, mostly non-pitting. So myxedema, and of course the T4 will give you an idea, and the TSH will be markedly here very, very low or almost undetectable in a setting of hypothyroidism, myxedema. A triad, here comes a triad, very simple: severe headache, palpitations, and sweating, and that's a clue for the pheo. And you know the pheochromocytoma is always on the boards, by the way, just so that you know. You may not see it in clinics for years and years, but just so that you know, although in the specialty cardiology or hypertension clinics one may see pheos, not too uncommonly. I mean, maybe once a year or something you'll come across, because these patients are on a tertiary center and they're being referred. Again, here you do the metanephrines in the urine. You look at the VMAs. So obviously, you're looking at VMA, for instance, in the urine. You're looking at metanephrines in the urine as well as in the serum. And so metanephrines will be very, very high, and so will the norepinephrines and serum norepinephrines as well. So that'll give you a clue here, and of course that's led on by a nuclear scan to get a MIBG, we call it MIBG scan. Sometimes a CT scan is very helpful earlier, and a CT scan of the abdomen. And sometimes the pheos are not even isolated. They may not be in the abdomen. They could be sitting in the thorax or along the sympathetic chains, etc. So, you know, it's a very intriguing secondary hypertension, if you will. And it's more academic, more clinical, more than clinical. Malignant, but normally I would not do a whole $1 million workup here on unless you have symptoms, because pheos are always symptomatic. Remember, if on the boards they say that this patient is asymptomatic, pheo is pretty much ruled out. So pheo is always symptomatic. So if they give you this triad of headache and palpitations and sweating, and then of course you start working that patient up for this. Another clue for pheo is specifically if the pheo patients they become markedly hypertensive. They are very severely hypertensive soon after surgery or during surgery, and that may be the first clue of pheo, by the way. So these patients can, right at the first nick as the surgeon starts operating, and this patient never had a history of hypertension whatsoever, and suddenly now the blood pressure shoots up, and intra-op and post-op the hypertension is noticed. So that's another clue they might give you for pheo. Okay, so that'll be on the boards definitely. Malignant accelerated hypertension is another clue for secondary hypertension, where patients at the age of 40, 35, or 45, that means it's occurring earlier, and they're very, very malignant. That means they're progressively causing a lot of target organ damage, like papilledema in the eyes, or they are causing retinopathies. They are causing, so either in the eyes, for instance, or in the kidneys, There may be albuminuria and glomerulopathies will start to occur. There might be peripheral vascular disease that starts to occur. There might be myocardial infarctions that may occur. So these are all organ damages that malignant accelerated hypertension conforms with. Drug-resistant hypertension is another category where routinely people are being assumingly that they're being treated for essential hypertension. Turns out that now they have their hypertension is becoming more resistant. The usual dual triple therapy is not working. That also gives you a clue. For a secondary hypertension, please mind you. And an acute rise, like patients who had controlled blood pressure, for instance, for a long period of time, and now all of a sudden at the age of 55 or 60, they have an acute rise of high blood pressure that's occurring, and that hypertension is getting more disturbed, if you will. And then that gives you a clue that renovascular hypertension is setting in, or maybe there is another cause of hypertension like a thyroid condition, or maybe perhaps a pheo is starting to occur. So these are some of the indications where there's an acute rise. A labile course will be seen. These patients don't have any more stable hypertensions, etc. Sleep apnea is one of the categories we have enumerated at the end, but this is classical where patients are very, very obese. Obviously, they have narcolepsy where they tend to sleep sitting in the chair like at work, or sometimes, God forbid, on the steering wheel, and that's very dangerous. But they are markedly obese, they're grossly overweight, obviously, and they have ventricular arrhythmias, and sometimes it could be resulting into sudden cardiac death. So they could be lethal arrhythmias as well. So these patients really should go through sleep studies and identify themselves that they are having these apneic episodes where their breathing stops, or sometimes their partners will tell them, their wife or their husband, the spouse or the significant other will define that the person stops breathing for several seconds, and he gets very, very worried and tries to wake him or her up, and then the whole breathing again begins to become normal, and then again until the cycle again repeats when he or she falls asleep, and then again there is an apneic episode. So it could be very, very dangerous also, as I said, both for the family as well as for the person, obviously. So these are some of the clues that I've just given you. Hardening of the arteries is typical in essential hypertension. Coarctation of the aorta will be heard by a bruit, and of course you'll have hypertension in the upper extremities. And there will be more so than the lower extremities, obviously, because of the coarctation here. And the clue is also that there are delayed pulses. The pulses in the femoral area. So the femoral artery will have delayed pulses. Just remember that. So that's another clue for the coarctation. And essentially, chronic kidney disease will be identified by the creatinines. Malignant hypertensions can be identified by various target organ damages, like I've pointed out, to the eyes, the kidneys, the peripheral vascular disease, and of course earlier MIs that tend to occur in these patients. And just be cognizant. The whole idea is wanting to give you in this quick video vignette is what are the possible secondary hypertension, and the idea is not to do the entire $1 million workup in all patients where you suspect a secondary hypertension. So therefore look for the clues and start to track on those, and you'll be surprised that you'll arrive to a diagnosis rather quick. Okay, wonderful. Thank you so much again for your attention. Stay on MuniMeterHealth, stay healthy, and stay heart healthy. Okay, and until I see you again into the next video for a new subject.